Welcome to this comprehensive PTCB study guide on cardiovascular drugs. This video will review the major drug classes, their mechanisms of action, and clinical applications, which are essential pharmacotherapy knowledge. We begin with blood pressure classification. Normal blood pressure is below 120/80. Stage 1 hypertension, 130 to 139 over 80 to 89, often requires initiating pharmacologic therapy. Cardiovascular pharmacotherapy involves key families like RAS modulators, beta blockers, and diuretics, crucial for managing heart conditions. RAAS modulators include ACE inhibitors, ending in PRIL, and ARBs, ending in SARTAN. ACE inhibitors block the conversion of angiotensin 1 to 2, causing vasodilation. A common side effect is a dry cough. ARBs directly block angiotensin 2 receptors and do not cause the cough. Both are first line for hypertension and heart failure. Beta-adrenergic blockers fall into three categories: BETA1, selective, non-selective, and combined alpha-beta blockers. Selective blockers, like metoprolol, primarily affect the heart. Non-selective blockers, like propranolol, affect both the heart and lungs, so they are contraindicated in asthma. Never stop any beta blocker abruptly. Diuretics are categorized into loops, thiazides, and potassium-sparing. Loop diuretics, such as furosemide, are the most potent and cause hypokalemia. Thiazides, like HCTZ, are first line for hypertension. Potassium-sparing diuretics, such as spironolactone, can cause hyperkalemia and are often combined with other diuretics to prevent potassium loss. Calcium channel blockers are split into dihydropyridines, DHPs, and non-dihydropyridines, non-DHPs. DHPs, like amlodipine, primarily cause vasodilation and can result in peripheral edema. Non-DHPs, like verapamil and diltiazem, affect both the heart and vessels. They are used for rate control in arrhythmias and should not be combined with beta blockers. For heart failure, 4 drug classes show mortality benefit: ACE inhibitors or ARBs, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. Loop diuretics only manage symptoms by removing volume. Novel agents like RNS, sacubitril/valsartan, offer improved mortality benefit over ACE inhibitors alone. Anticoagulants prevent clot formation. Heparins are parenteral, with LMWH, like enoxaparin, offering predictable dosing. Warfarin inhibits vitamin K-dependent factors and requires INR monitoring. DOACs, such as apixaban, are direct factor XA inhibitors that require no routine monitoring and have fewer interactions. Antiarrhythmics are categorized by the Vaughan Williams classification. Class 1 are sodium channel blockers. Class 2 are beta blockers. Class 3 are potassium channel blockers, like amiodarone, known for multi-organ toxicity. Class 4 are calcium channel blockers. These drugs can be proarrhythmic, so use requires careful consideration. Nitrates are potent vasodilators used for angina. A critical contraindication is the concurrent use of PDE5 inhibitors due to profound hypotension risk. Statins, HMG-CoA reductase inhibitors, lower cholesterol. Side effects include myalgia and rare rhabdomyolysis. Antiplatelets like aspirin and clopidogrel prevent thrombotic events. Be aware of these high-yield exam traps. Remember the ACE inhibitor cough, the hyperkalemia risk with spironolactone, and the need to avoid combining non-DHP calcium channel blockers with beta blockers. Finally, recall the specific agents that confer mortality benefit in heart failure. To master the essentials, focus on understanding drug mechanisms, critical contraindications, and potential drug interactions. Knowing these core principles and the key exam traps will distinguish your expertise as a competent pharmacy technician.